Hi, everyone. Thank you for joining today's webinar, Maximize Revenue Through Coding, Documentation, and Denial Management. Today's program will be presented by Maureen Doherty, Manager in Withum's Healthcare Advisory Team. Before we begin, I have a few notes. At the bottom of the toolbar on the right of your screen, you will see a questions box. Feel free to send us your questions during the presentation. We'll do our best to address them at the end. There will be 4 polling questions throughout the program. To qualify for CPE credit, you must participate in each poll. CPE certificates will be emailed to you within a few weeks. And finally, once the webinar is over, there will be a pop-up asking you to complete a survey of today's webinar. Please take a moment to complete it. It is our way of being able to provide you with the best and most relevant programs possible. With that, I will turn it over to Maureen.
Good afternoon, everybody, and thank you for joining the webinar. What we're going to review today are the key 2022 coding and documentation updates, discuss provider and staff education, and also denial management. So for 2022, there were 405 changes, which included additions, revisions, and deletions. Out of that 405, there were 249 new codes that were added. And each CPT section had changes, both in codes or guidelines. Most of the significant changes are to the evaluation and management codes, also arthrodesis and laminectomies of the spine, cardiac catheterizations for congenital anomalies, lab pathology, and COVID-19. And the difference with the COVID-19 vaccinations, those codes now include the type of vaccine and the number of doses. So new and established patient codes, 99202 to 99205 and 99212 to 99215, no longer require the 3 components, which is history, exam, and medical decision-making, or time for counseling and coordination of care. One thing I'll note on this particular bullet is that 99201 is no longer a valid code. That was dropped this year in 2022. As far as the 3 components that I just discussed for medical decision-making, I have found in many audits that I've done that area for physicians have, or providers, I should say, have, sometimes a difficult time in meeting all 3 of those, the components for medical decision-making itself. And that usually is the number of diagnoses or the management options, amount of data that was reviewed, risk or complications of morbidity or mortality. So those 3 components still apply, but counseling and coordination of care is going to be reported for total time spent on the day of the visit. Which is much easier than before. You had to do the counseling and coordination of care, and that had to be more than 50% of the visit. Now, when you're doing total time, it's the total time that includes prepping for the visit. So if you're reviewing labs, or you're reviewing the patient's chart, or any additional paperwork that came from another provider, the actual visit, documentation for that, and your face-to-face time with the patient. So that is all considered now within the total time. You do need to do a medically appropriate history and exam, that's required, but the CPT code itself is determined by the level of medical decision making, or the total time spent on that day of the visit. The one thing I will say about time, and I saw this with counseling and coordination of care as well, have had issues. I'm going to use one particular issue where a physician was being audited by the insurance company, and I went to go review the notes. And this is right back when EHRs actually first started, and her documentation was impeccable. And I am sitting there, and as I'm going through each one, trying to determine, okay, so what is the issue that they, think she's being fraudulent here? And as I looked at the bottom, every single patient she saw was for 60 minutes. So obviously there's only 8 hours in a day, and she was seeing 20 patients, 8 hour in a work day, I should say. And she was seeing, 25, 30 patients a day. So obviously the time that she was billing out for obviously did not exist. But the number of minutes now required for each code has increased, and that's on the next slide. So it's spanned quite a bit here. So as you can see, it goes anywhere from 15 to 29 minutes for level 2, all the way at, for 205 is 60 to 74 minutes that you spend with the patient and that you could document that time. And on the established patients, anywhere from 10 to 19, all the way up to 40 to 54 minutes.
And we are on to our first polling question. Do you understand the new documentation guidelines for new and established patients? About 20 more seconds. All right, I'm going to go ahead and close it out. And here are the results. So looks like the majority of you voted somewhat.
Okay. Okay, so the next slide is for principal care management. This is new to 2022 as well. The CP codes for PCM are 99424 to 99427, and it's created for principal care management. PCM services are for both physicians and qualified healthcare professionals to report management services for patients with one complex chronic condition. So there's, excuse me, 4 additional codes. 99424 is for the first 30 minutes, and this is per calendar month. 99425 is for each additional 30 minutes per calendar month. Anything less than 30 minutes in a calendar month is not reported separately. And then the other 2 codes, the 99426 and 99247, are for clinical staff time, which is directed by a physician or other qualified professional. So if other clinical staff, you have a nurse or a medical assistant who's creating care plans, doing follow-up phone calls with the patient or regarding the patient, you can bill those codes as well. So in order for a patient to be covered by PCM codes, they have to meet the following criteria. So they have to have one complex chronic condition that lasting at least 3 months. It has to be severe enough that the patient is at risk for hospitalization or was recently hospitalized due to the condition. And the condition requires development or revision of a disease-specific care plan. Rachel, can you go back, I'm sorry, just to the code, the one that had the codes with the different, one more, I think. Yeah, right there. I just wanted to just go over also some of the fees for this, or the reimbursement for this. So the 99424, and these are only by Medicare, because regular private payers can keep their own policies. So these policies that I'm showing you today are strictly for Medicare. So 99424 is paying approximately $83 a visit. The 99425 is $60. The 99426 is approximately $63. and the 99247 is approximately $48. The other thing is on these codes, if you're doing principal care management, Medicare has assigned a modifier, and that modifier is the letter F, like in Frank, and S, like in Sam. So you would use the FS modifier with any of these PCM codes. All right, so the condition, again, the chronic condition that this patient has requires frequent adjustments in the medication regimen, or the the management of the condition is usually complex due to comorbidities. The patients must consent to receive these services. So if you are providing PCM services, you should have a consent form drawn for the practice so that the patient signs that, and you have that, you can keep that within their record. And they're responsible, just like any other Medicare visit, that they would owe the 20% beneficiary cost sharing for this service. So chronic care management 99491 was previously created last year in 2021 is when that CPT code came out. It is provided personally by a physician or another qualified healthcare provider, and it's for the first 30 minutes with the following elements, which would be multiple 2 or more chronic conditions that are expected to last at least 12 months or until the death of the patient. Chronic conditions place the patient at a significant risk of death, acute exacerbation, decompensation, or functional decline. That particular code is paying approximately $74 for the 99491. So the new code that they added is 99437 to go with that code, and that is just to add if the patient is seen an additional 30 minutes, it would be that code you could use for that addition. Split and shared visits, again, specific to Medicare, and also private payers can keep their own policies. So again, this is strictly for split and shared visits. So the split and shared visits in the facility setting only. So it's place of service 21 or 22. And it's billed under the MPI of either the physician or the non-physician practitioner who actually has the substantive part of the visit. So they document, whoever is documenting the support for the history exam or medical decision making for the visit, or is providing more than 50% of the service time. So some of the issue, and I apologize, I spoke incorrectly on the previous slide with the FS modifier. The FS modifier is for split and shared visits. But with the guidelines here on the split and shared visits, the majority of the time, usually the nurse practitioner or PA will be the person who goes in to visit the patient and do most of the documentation and spend the most time. And usually the physician will go later and review everything, meet with the patient, and sign off on everything. So when you're billing under the physician, if he was the one who actually was doing more time, you would get paid 100%. He would get paid 100% of the Medicare reimbursement. However, nurse practitioners, the non-physician provider PAs are paid at 85% of the physician fee schedule. So obviously you're getting less money if it is the nurse practitioner or PA who is doing the biggest portion of time with this patient. It does not apply to office visits, which is place of service 11. Those services, when a nurse practitioner or a physician are seeing a patient, should be billed as incident 2. So you're billing it underneath the physician's MPI number. and the physician obviously just has to sign off on that visit as well. Even if they're not seeing that patient at all that day, they still have to review and sign off on that. So split and share visits are allowed for both new and established patients, initial and subsequent visits, critical care services, prolonged E&M visits, and skilled nursing facility E&M visits. And documentation must identify the physician and the MPP who performs the visit.
Okay, we are on to our second polling question. Split shared visits are able to be performed both in the office and hospital settings. True or false? About 20 more seconds. I'm going to go ahead and close it out. And here are the results. Looks like 54% voted true and false.
Okay, next we're going to go over provider and staff coding education. Coding and documentation plays a key role in quality patient care. Providers and staff obviously should be educated annually when the new codes and changes go into effect every year on January 1st. And that list of new, revised, and deleted codes are usually published in October. So there's, a few months in order for everybody to be aware of what the new codes for your particular specialty are. I know that there are many EHR systems that load them for you, but it's good to actually know which codes are new for your specialty so that you can enhance reimbursement by utilizing those codes. Accurate documentation and complete and compliant coding obviously impacts all areas of the quality reporting and ultimately provider reimbursement. Documentation is very key, and there are many times that the documentation that is being documented is not necessarily supporting the codes that are going out. So practices should consider doing annual coding audits in education. You could also do quarterly coding audits if you just want to make sure that you're not running into issues where you're undercoding, so you're losing reimbursement, or you're overcoding and you're putting yourself at risk for an audit by the insurance companies. And once you have the audits done, you also will catch any errors that you can recapture and rectify mistakes going forward. It could increase your revenue, and also it will keep your revenue, your documentation compliant. And once the once the audit is complete, usually you can do either a group education on based what your findings were and what should be implemented to make any corrections, or you can meet individually with the different providers on their own documentation just to see if there's anything that they need to make improvement on. So coding and documentation issues. So insufficient documentation, I would say, is the number one reason for a documentation issue. It's not supporting the codes that are being built out. No documentation, because I have seen that many times where there's a visit, but there's no documentation for it. No physician signature. Obviously, it could be electronic, or if there are physicians still doing paper, it has to be a written signature or electronic. So that is one of the requirements for your documentation. And that is another area where I have in the past seen that it's not done. So those things always, physician signature is always required. No modifiers or incorrect modifiers. That's more on the billing piece of it, but the providers need to be aware when they are documenting and then they're entering their codes in, that they know which codes need modifiers and that those are applied, so that by the time it gets to the billing department, it's something that can go out and be billed, and with no issues of it coming back as, a denial issue. Incorrect coding of the E&M services to support medical necessity and accurate billing of E&M services. And that, again, basically goes with the first, with the insufficient documentation. Okay, so there's either incorrect coding of the E&M, so it's a higher level, or, usually it's a higher level, but the medical necessity is not supported in the documentation itself.
All right, we're up to our third polling question. Are you proactive in providing education to providers and staff regarding CPT or diagnosis changes prior to January 1st? About 20 more seconds. All right, I'll go ahead and close it out. And here are the results. The majority voted sometimes for this.
Okay, denial management. This is probably the biggest area that we're going to touch on, because this is where it's the most important work for the medical billing, and it is also the most overlooked for a lot of reasons. So before I even get into the top denial reasons, I just want to touch on a couple different things that I've experienced in medical practices when it comes to the medical billing, denial management. So the accounts receivable. I had one particular practice that I received a phone call from the practice administrator telling me that they were unable to make payroll. And she had no idea why, and their practice is busy and they're seeing a lot of patients and the doctors are documenting, but she had no money coming in. So I had done a revenue cycle assessment there, and the revenue cycle assessment obviously starts from the very beginning, from scheduling to the doctor doing the note, or I'm seeing the patient, the charge entry, the follow-up, the insurance follow-up, the patient follow-up, payment posting. So it just goes through every aspect of the revenue cycle. So in doing a review, when I was done, I went back to the administrator and I said to her, I know exactly why you cannot make payroll. And she said, well, I can't imagine what it could possibly be. And it was the billing manager, when I interviewed her, said to me during that session that she had not sent out bills in 4 months because she was too busy and too backlogged. So obviously that is a serious situation, both for that employee and also for the practice. And so they had to retain other new employees just to get caught up just on that 4 months of billing that never went out by the practice. I have other practices that had an AR over 120 days, 76%, which is leaving only 25% for your 0 through 75%. And the other issue too is that most practices aren't significantly staffed in the billing area. They have, due to the pandemic, a lot of employees had left. A lot of them have not come back. Practices are having a vast difficulty in retaining or hiring new help. So in all those areas, it's causing a deficit in the billing departments. I had a similar practice that, because of that, they had 5 employees originally. It then went down to 2 that they had in the practice. So one was attempting to do all the billing, and the other person was supposed to be doing AR. They ended up hiring an additional 2 people, so now they're back to 4 people, and they had that person who was doing the accounts receivable went out on medical leave, and so AR was not getting done. And even when she came back to the practice, because they still only had 4 people, and now the accounts receivable is so large, and there was other work to do, the AR got pushed to the side. And I find that a lot in medical practices, that the AR is not worked as seriously as it should be, and it causes a lot of financial impact on the practice. There's a lot of AR that has to be written off because of timely filing, and they can no longer utilize that. Or other practices, their accounts receivable are so high because nothing is written off, even though it's something that may not be collectible after a certain period of time. So those are some reasons why denial management is so important to the practice. So some of the top denial reasons that there are is patient coverage is not in effect at the time of service. Coverage is secondary to the patient. So usually coordination of benefits, that should be addressed with the patients when they come into the office. Incorrect patient name, date of birth, insurance ID numbers, timely filing, right? So that timely filing is more on the medical practice side, that claims are not submitted within 90 days. And that's 90 days is the general time frame for insurances to deny a claim for timely filing. And if that happens, you're not able to file that claim again. So hard denials are denials that can't be corrected or reversed and result in being written off, causing lost revenue. And soft denials are provisional denials with potential to be reimbursed if the provider amends the claim or sends further information, documentation in. Some more top denial reasons, it being medically not necessary, additional information requested. Those kind of go hand in hand, because if something is considered not medically necessary, if you send in documentation to support that, then the claim will be paid. The procedure doesn't match the diagnosis. It's inclusive to another service. Usually if it's inclusive to another service, you're able to add a modifier to that, and it will have the claim will get paid. Incorrect place of service. I don't see that too often, but that does happen where somebody's billing for an office visit when it really was a service that took place in a hospital. and medical documentation requests, as I had indicated. So denial management starts at the front desk. So collecting copays and patient balances at the time of service is critical to your patient's, your practice's revenue. Insurance eligibility must be checked at every visit. And I apologize if you're hearing anything in the background because they came to mow my lawn and it is not their day to mow the lawn, so I apologize if you're hearing anything. Denial management in the billing department, accounts receivable is the biggest non-worked area, which we just discussed. Medical practices should consider hiring a denials management staff person. This person should be somebody, and it could be more than one person depending on the size of your practice, that denials management, that's all they do. All they're doing is working accounts receivable or following up on denials that are coming into the practice. A lot of practices utilize a billing manager or an office manager to oversee that. But in that regards, and again, if it's a larger practice, you should definitely have a denials management person in charge, even if they have other people underneath them working on accounts receivable. You should always be measuring, tracking, reporting trends by department, doctor, procedure, and payer. And all of this should be done on a monthly basis just to see where your AR is. And then you would be able to see right away, is there an issue with a department or one of the physicians is not submitting their claims on time or not providing the documentation on time for the claims to be submitted? Are there certain procedures that are continuously being denied, and how can that be fixed? And is it specific payers? And a lot of times it's specific payers where certain claims they're just not paying, certain procedures they're not paying. I have had instances where a practice had not been paid by, it was actually Horizon Blue Cross Blue Shield for a few specific CPT codes that were payable. And I believe they owed them over $60,000. So that was identified, which is good. But the issue is you then have to follow up with that insurance company until you get that money that's due to you, because a lot of times you'll send in everything you need to send in so that they work that project, and the project doesn't get worked. And on the flip side of that, the majority of payers now are also very shorthanded since the pandemic. And so even getting just to a provider relations person or a specific contact for your practice has become much more difficult. And things getting looked at as well. It takes a little bit more time than it did before. And the other thing is you should consider retaining professionals to perform a revenue cycle assessment for your practice. It's very important for you to see exactly how your practice operates. And again, it starts, at the very beginning, scheduling, registration, the billing piece of it, coding piece of it, billing, and in billing, the accounts receivable, payment posting, insurance payment posting, patients collections, insurance collections. All of that is encompassed within a revenue cycle assessment, and you'd be surprised as to how many things truly could work better if there's something else that's implemented. All right, so denial management, the best practices for denials management are, and I'm going to be honest when I say this, these are the best practices, and in all the years I've been doing this, I've seen people with low, denials and their accounts receivable being, fairly good, and the average days in the AR same. But I've never seen them this low. But this is what the best practices are. So it's something that every practice should strive to do. And even though if you don't get close to those numbers, but you're a little bit higher, it still means that you're doing very well with your denial management. So keeping denials in general under 5%, total accounts receivable, AR should, obviously it's AR, should be less than 12%, and then average days in accounts receivable should also be under 40 days. That is pretty much what I have here. So, okay, so there's one more. So additional ways to increase your revenue is first doing a revenue cycle assessment. And again, most revenue cycle assessments come with, recommendations and implementation for what should be done so that you can have a better revenue cycle in your practice. Insurance contract negotiations are very important, especially for specialty practices. Most insurances do not negotiate for primary care. But if it is a specific specialty and you have not negotiated your contracts in quite some time, it's something to consider. And the ranges in enhancing your reimbursement could be significant. And it's based off of a bunch of different ways you can negotiate the contract, whether it's just an overall percentage of Medicare. So if you're currently getting 80% of Medicare, you may be able to get 120, 125% of Medicare on all of your codes. Some insurances, depending on the specialty, will only allow you to do carve-outs. So those carve-outs are more for your high volume codes that you're going to use. And maybe they'll do 20, 25 of those codes and negotiate those rates. Or, they can also do rates that will increase over, if your contract's 3 years, it could be an expanding in percentage. So maybe you start at 110%, the following year 115%, and the following year 120% of Medicare. But the difference in reimbursement for yourself and the revenue coming into your practice will increase significantly. And the other thing is the coding and documentation reviews that we discussed. Those are very, very important as well, because you can be losing a lot of revenue if you're not documenting properly, and you're undercoding, which a lot of practices do. So you're losing out on the difference between, say, a 99203 and a 99204. And now that you're allowed to use the time, the total time spent with your patients, that also should give you significant increase in your revenue as well. So depending on the time, if you are spending that time that you can bill a level 4 or level 5 based on that, then you're going to increase your revenue going forward. And the other thing also with the coding and documentation reviews that I mentioned previously is also the education that goes to the providers, so that they're fully aware of what they're lacking in, that they need to make sure they're very specific about in their note. Okay. So I believe, oh, there you go, Rachel.
So we're on to our fourth and final polling question, and then we have a couple of audience questions to go to. Reminder, in order to get CPE credit, we all need to remain on until 12:50, so please feel free to write in any additional questions, and we will do our best to answer them in the time that we have left. So our fourth polling question: do you understand the financial impact of not having a strong denial management team? Give about 10 more seconds. All right, I'll go ahead and close it out. And here are the results. All right, so looks like that's good. The majority of you completely understand the impact of having a strong denial management team. Okay, so our audience question, one of them was, please tell us again where split and shared visits can be used.
Okay, so split and shared visits can be used only in the hospital. Or a facility setting. So it could be a hospital, inpatient, or it could be a clinic. So either the place of service 21 or 22. If it is done in a office, then it's incident 2. It's not considered a split and shared visit. It's only facility based.
Great, great, thank you. And are there any other questions? Please feel free to write them in. And Maria, I just have a question for you, just in response to one of our other polling questions about providing education to providers and staff regarding the changes prior to January 1st. In what ways can providers provide education? Would it be having someone like you speak to them, or are there any other tools that they may be able to use?
Exactly. I mean, for the most part, it's better having an outside source come in to educate the providers, and kind of going over with them or the staff in general what the new changes will be. So it would be providers. You could use a billing staff as well, because it's just more comprehensive as far as what information would be provided to them, and there's a better understanding of what the codes are and so forth to explain to the providers as well.
Great, thank you. And also a reminder to everyone, we will be sending out the recording and the slides either later today or later this week. The slides are also available to you within your attendee toolbar. And just we have about 5 minutes left. Again, feel free to write in your questions. Maureen, are there any other stories in your experience that may be helpful to the audience on here that they can be mindful of just in their practices?
Well, the biggest area, again, that I mentioned previously is definitely the billing side of it. In all of the assessments, revenue cycle assessments that I have done, the majority of the issues tend to fall in that area. And again, it's more so a lot of times because there's lack of the right staff or the number of staff. There are, and I'll use another example also of the practice I mentioned earlier that had an accounts receivable over 120% of 75%. They had a billing manager, and she was working on projects such as insurances that did owe both money. Okay, but because of the AR, the only thing anybody was doing in that practice was submitting the claims and sending them out. There was really no follow-up. Denials, if they came in, they were working them, some of them I should say, but nobody looked at the accounts receivable. And so that there is key in any practice, that the accounts receivable, somebody should, this is again why talking about having a denial management person, there has to be somebody who is looking at that constantly, because I don't know any practice that has a very low, perfect, accounts receivable percentage. And it's very easy to just put it aside because there's so much work to do and the staff is overwhelmed. So it's either looking to hopefully hire additional people that you can assist with the AR, or even just in the billing department. So it gives whoever is working on AR, some assistance there. And that, alone should help. But again, I know a lot of people are having issues hiring people, and hopefully that turns around very soon, and that those things can be done. But that is the key, is just having the correct amount of staff, making sure people are looking it over. It can be broken up, obviously, by insurance companies. So maybe one person is working on Aetna and Blue Cross, somebody else is working on Cigna and United Healthcare, somebody's working on Medicare. Any of those breakups within the accounts receivable is very helpful. Or you can also break it up by the AR time period. So you have somebody who does 31 to 60 days, somebody else who does 61 to 90 days, and someone who's working on the over 120 days. Those are the best ways to really have your AR money come back into the practice.
Great, thank you. We had a couple other questions come in. How can you utilize technology or technology offerings to improve revenue cycle generally and denial specifically?
They do have denial management software. I'm off the top of my head, I'm not certain of exactly what the names of those are, but if you want to leave your information, I can definitely find out that for you. A lot of times the EHR that you're utilizing also will have some denial management pieces that you can add to your EHR that you could put into through where your billing is, and it will track everything. It will track your revenue. It'll track, your denials. It will track your accounts receivable. So that would be the first place I would check, is with your actual practice management software or EHR. And if not, again, if you want to reach out to me, I can definitely get you some names of some software that can assist you with that.
Great, thanks. And then our last question, how are your physician office clients doing now, kind of at the end of the post-pandemic? Has volume come back? Has AR increased?
Okay, so patient volume has come back tremendously in most patients and most practices, and they're also doing telehealth as well. So their patient volume is definitely picking up. Again, as I mentioned earlier, what I'm finding myself is that most practices in the billing area usually are short-staffed to begin with, and were extremely short-staffed due to the pandemic. And the only issue that they have had recently that I am aware of is that they're having difficulty hiring. There's not enough billing people out there right now. But one of the things you can do, a lot of times if you go to the American Academy of Procedural Coders, AAPC, they have a list of coders, but within those coders, a lot of those coders are billing people as well. And they post positions on AAPC for jobs that people are looking for. So that's another avenue that they could look at. If you want that information, you can reach out to me. I can give you the information where to find that. But those are the two key things. I mean, again, I'm hoping the volume builds back up, but that's what I've been seeing lately.
Awesome, thank you. So we are currently at the 50-minute mark. I can leave the webinar running for a couple more minutes in case anyone joined late, just in order to ensure that you reach the 50-minute minimum for CPE credit. But everyone else, thank you so much and have a great day. Thanks for joining us. We'll send the materials out either later today or later this week. Thank you.